Suresh here, your Games Academy faculty for Biochemistry. As a part of Fmge test series Youth Session 2023, I come up with a series of case-based discussions on a daily basis. So, as for today's session, the case what I'm going to discuss under anemia. Okay. So, the case scenario is here like this: a 62-year-old man being treated for tuberculosis develops microcytic hypochromic anemia. Ferritin levels are increased and marked sideroblastosis is present. The probable cause of anemia in this case. The options are anemia of chronic disease, iron deficiency anemia, X-linked sideroblastic anemia, and option D, B6 deficiency. So the key points what you are supposed to know is the person is aged, his age is 62 years, and he is under treatment for tuberculosis. That means he is using anti-tuberculosis drugs. Maybe it might be the reason for development of microcytic hypochromic anemia that we have to sort out. Ferritin levels are laboratory values. If you see ferritin levels are increased, and sideroblastosis pathological studies clear that sideroblastosis is observed. So, what might be the reason for the anemia in this case? Right. So, let us first exclude the choices which are wrong. First option, anemia of chronic disease. It's not the correct option. Why? Because anemia of chronic disease presents as microcytic hypochromic anemia because chronic inflammation reduces iron availability. Okay. Ferritin level is also elevated because ferritin is a positive acute phase reactant. In chronic diseases, obviously ferritin levels will be elevated. However, sideroblastosis is not a feature of anemia of chronic disease. So one of the key features in the case we have noted that sideroblastosis, which is lacking in anemia of chronic disease. So that's why we have to exclude this choice. Next choice, iron deficiency anemia. So here iron itself is not available, that's why anemia. Then how come ferritin level will be elevated? So ferritin levels will be low in case of iron deficiency anemia, but here we got elevated ferritin levels. So option B also supposed to be excluded, right? And then option C, X-linked sideroblastic anemia, which is caused by deficiency of ALA synthase 2, and the presentation of X-linked sideroblastic anemia is however expected to be earlier stage. Okay, maybe from the childhood stage to attaining the adulthood stage, but here our patient is having 62 years, he is almost old aged, right? So this is also not the probable option, so option C also supposed to be excluded. So the leftover option, that is option D, B6. Yes, this microcytic hypochromic anemia is because of microcytic hypochromic anemia because of B6 deficiency. And what might be the reason? Here we have noted that the person is under treatment for tuberculosis. So the anti-tuberculosis drug, that is isoniazid hydrazine, is a structural analog of pyridoxal, which is going to inhibit pyridoxal kinase, the key enzyme which convert pyridoxal to pyridoxal phosphate. Yes, remember, any B complex vitamin you take, they do have superactive forms, I mean coenzyme forms. So the coenzyme form for B6 is PLP, which has got crucial role in protein metabolism, at the same time in heme synthesis. Heme synthesis, the key enzyme is ALA synthase, which is totally dependent on PLP. If PLP is not there, ALA synthase will be inactivated. There is no further proceeding of heme synthesis. So PLP deficiency causes reduction in the rate at which protoporphyrin is synthesized. Without protoporphyrin, iron cannot be incorporated into the ring in RBC precursors. This iron accumulates in the mitochondria of RBC precursors or erythroblasts. Such iron-laden macrophages surround the nuclei of erythroblasts, form a ring sideroblast. So pathological studies clearly indicated there is a sideroblast. Yes, in B6 deficiency there is a sideroblastosis. Hence, intake of isoniazid hydrazine causes microcytic hypochromic anemia with ring sideroblast by causing B6 deficiency. Remember, if the person is under the treatment for tuberculosis, he is definitely supposed to be supplemented with B complex vitamins, especially B6. Why? Because this tuberculosis treatment may cause the patient to undergo vitamin deficiency, exclusively B6 deficiency. It has got other effects like anemia, microcytic hypochromic anemia. So always it is better to supply anti-tuberculosis drugs along with the B complex supplements. Hope the session is fruitful to you. Thanks for watching. Thank you.